Well, a warm welcome to you and welcome once again to the program Transforming Lives One at a Time. On this program, it is our hope that your lives will be positively impacted. We want to provide you with information that is relevant, inspiring, and bringing that hope to homes, to lives, to communities, that you would become better versions of yourselves. We seek to provide solutions for the many issues that we face on a day-to-day basis on this journey we call life. Well, today we are going to be addressing a topic that has touched the lives of most persons around the world. Maybe you would have had a family member, a friend, or a co-worker succumb to this dreaded disease we call cancer. My guest today is no stranger in this field, and he's here to give us vital information relating to cancer. Dr. Anthony Thompson is a fixed house officer at the Oncology unit of the Tobago Regional Health Authority. Dr. Thompson graduated from the University of the West Indies, St. Augustine in 2003 after completing his internship and 1 year as a house officer in the adult medicine department at the Port of Spain Hospital. He worked with the National Radiotherapy Center in St. James from 2006 to 2010. In 2010, he became part of the TRHA's new Oncology unit, where he worked from 2010 to 2013, and then from 2019 to present. Dr. Thompson holds a master's degree in public health with the University of London. Dr. Thompson, welcome to the program. It's a pleasure having you today.
Thank you very much, Ms. McCletchy.
Yes, Dr. Thompson, this disease called cancer has been weighing heavily, I would say, on the general population for a number of years. But within recent times, this disease has been literally topping the charts. Just 2 weeks ago, I lost a classmate to this disease. And of course, the stories are endless. We would hear persons passing away from, other illnesses, but cancer seems to be that recurring decimal. And I think that I could speak for the general populace that we have all come to hate it. I can't butter it up. I can't sugarcoat it. So we want to have a very candid conversation today as we uncover the truths and realities about this disease. So first things first, tell us, what is cancer and what are the effects on the body?
Okay, so to answer the question, first you have to think about what your body is. So don't think of your body as a homogeneous body. You're actually a community of about 30 to 40 trillion cells. And each of these cells has a function to perform, and they all have to cooperate and work together to produce the experience that you have as life. So what cancer is, the term cancer refers to a group of diseases where the abnormal growth of a group of cells, usually descended from one single abnormal cell, right? That unrestrained growth, as well as invasion of surrounding normal tissues and potential spread to distant sites from the point of origin, is what we experience as cancer. So it begins with a genetic abnormality, an abnormality in the genes that code for the function of a cell, that then leads to unrestrained growth. And then later on, further genetic abnormalities occur, which can lead to invasion and, of course, spread. Now, the effects of this, one is that you have loss of function of the normal tissue. So, for instance, if a cell were, let's say, in your bone marrow, and the job of this cell is to produce other cells, that cell is in balance with the other bone marrow cells. But if it starts to multiply in an uncontrolled fashion, it basically competes and squeezes out the other normal cells. So over time, what you find is that the populations that were supposed to be produced by those other normal cells decrease, and you get a low blood count, or you get a low white cell count, or low platelets, etc. So basically, it is an abnormal group of cells that's outcompeting your normal cells and monopolizing resources, right? And of course, disturbing function.
Right.
Yeah.
What role does genetics play in cancer development and treatment?
Well, essentially, it's a genetic disease in the sense that the underlying event that triggers a cancer is going to be some disturbance in your genetic code, right? Now, when we use the term genetic disease, we often think of something that's inherited.
Yes.
So to some extent, many cancers have an inherited predisposition. So you either inherit a faulty gene that directly leads to tumor formation, or you inherit a faulty gene that increases your risk by preventing you from managing or metabolizing other environmental exposures in the same way. So for instance, a person who's genetically not able to metabolize the toxins from cigarette smoking, right, will have a higher risk of cancers caused by cigarette smoking.
Okay.
Yeah.
Okay. Well, I want us to talk about the various kinds of cancer, because I know that for the most part that cancer varies by region and population group. So what are the most common cancers for us here in Trinidad and Tobago? How do they typically present?
Okay, so you're looking at, you could get a cancer developing anywhere from the sole of your foot to the top of your head, right? But in terms of just common organs that generate the bulk of our cancer burden as a country, among women, you're looking at breast, bowel, cervix, and uterus, right? And among men, you're looking at prostate, bowel, lung as the commonest sites of origin.
And how do they, well, you answered how do they typically?
So typical presentations. So of course the presentation of a given cancer would depend on the tissue of origin, right? So let's just take some common examples. So for instance, a breast cancer typically will present as a lump in the breast.
Okay.
In addition to the lump, the woman may experience a nipple discharge, which may be bloody or blood-stained. On occasion, you can actually present with pain in the breast, right? If we jump over to the male side and we're talking about prostate cancer, typically prostate cancer is not detected because of the presence of symptoms, but because we screen for prostate cancer using a blood test called the PSA.
Right.
And that generally leads to it. But if you didn't participate in screening and your cancer had to reach a stage where it could present, typically prostate cancer in the later stages would present with pain, right? Pain because of deposits of the prostate cancer spread to your bones, right? Right. Pain, weight loss, lack of appetite, that sort of thing. If we look at bowel cancer, if you imagine what your bowel does, your bowel is basically a passage for food to stool to outside, right? If you have a tumor growing in your bowel, the first thing that you may notice is difficulty in passing stool. The other thing that often happens is that the tumor can bleed slowly into your gut. So what you present with is not the direct obstruction due to the tumor, but you present with a low blood count due to a lack of iron because of this constant blood loss.
Right. Yeah. So in terms of tests that you can run, it's very, very crucial that both male and female do the test, like the prostate exam and the pap smears and some of the things that we take for granted. And I know, of course, for men, a lot of men shy away from that prostate exam. I know that.
Well, interestingly enough, men have been doing a lot better.
Really?
Not because of prostate examination. They do tend to shy away from that. But the blood test is actually pretty acceptable to most people. Right. Most men will do a blood test. And then if the results are abnormal, then they'll go on to do an examination and then a biopsy. But in terms of the importance of testing, one of the limitations, it's important, I think, to have a clear view of the limitations of testing. So for instance, let's say I go to screen for prostate cancer and I do my PSA blood test, right? And it comes back normal, right? It doesn't mean that I don't have cancer somewhere else. It doesn't mean I don't have lung cancer or bowel cancer. All it says is that I'm unlikely to have prostate cancer.
Right.
Right? So cancer testing is very specific. So when a woman does a pap smear, the pap smear just assesses the mouth of a womb, the cervix.
Right.
It gives no information about what's happening 5 centimeters above that level in her womb itself. Yeah. So a lot of times people will have this story, well, you know, I just did a checkup.
Yes.
I did one just now, and you know, it's because we misunderstand what we're checking for.
Oh.
Yeah. So for instance, if you went and did a mammogram to screen for breast cancer, it doesn't give you any information about your lungs.
Correct.
Yeah.
Correct.
So you could pop up with lung cancer.
Wow.
Yeah.
Well,
So,
I wasn't looking at it from that, because I would have known a lot of persons who would have spent thousands of dollars, and they will do their annual checkups and stuff, and then on one checkup they're like, you're stage 4 cancer. How?
It's so every one of the things that I do think we grasp as a public are the limitations of testing.
Okay.
So oftentimes people will come to me and ask for a blood test for cancer.
Right.
And what they mean, and I think what sometimes the lab means, is what we call tumor markers.
Okay.
Right? So there are tumor markers that are associated with specific types of cancer, right? But they're not 100% sensitive. So you can have a tumor growing and your blood results are normal.
Oh.
A lot of times people assume if my blood test came back normal, I'm fine. You know, and it doesn't work that way.
Right.
Yeah, it really doesn't work that way. And then the other side of it is the regularity with which we do some of these screening tests.
Okay.
So some women will do a pap smear, for instance. Or in fact, let me use mammograms, a better example. They do a mammogram this year and not do one for the next 4 years.
Right.
Right?
Okay.
So I did a mammogram, I'm good.
Yes.
But each of these tests has a certain frequency that you need to do it to ensure that you don't miss something.
Got it.
Yeah.
Got it.
So your pap smear, roughly speaking, is going to be good for 3 years.
And then after you have to get it done again.
Get it done again. Yeah, your mammogram is going to be, for women at ordinary risk of breast cancer, is going to be 2 years. Right? For high risk women, it's going to be 1 year. Right?
Okay.
And if you go past that time limit, the chances are that something could pop up and it wasn't seen on the previous test.
Right. Because some persons tend to, say that cancer is one that creeps up on the unsuspecting, because you would be feeling fine, you would be feeling normal, regular, and then you would go one day and then stage 3 or stage 2 or stage 4.
Yeah. It is partially a function of how we utilize healthcare. So people will go to the doctor if they have a cold.
Right.
You have a bad enough cold and you couldn't sleep last night, you'll show up at your doctor's office.
Yes.
People will tend not to engage in activities that are preventative in purpose. Yeah. So they will tend not to spend thousands of dollars on a colonoscopy, for instance.
Okay.
But if they got a gas pain bad enough, they go to the doctor. So that's part of it, So a lot of times people, you'd hear this story, this so-and-so, he always by the doctor. How come they didn't find it?
Yes, right, precisely.
It's because he went to the doctor for specific things.
Oh,
what has to happen, though, is we as healthcare professionals, there are some things that we should be recommending more of.
Okay.
Every woman I meet, not socially, but professionally, should, hey, when was your last pap smear? Have you done your pap smear? Have you done your mammogram? Have you, and that's sort of a whole community/environmental shift towards earlier detection.
Yeah.
But even with that, there are only a handful of cancers that we have reliable screening tests for. Yeah.
Wow.
Fortunately, they're the ones that affect us most.
Okay, yes,
So our main cancers as a country would be prostate, breast, colon, cervix, right? And our main cancers that we can effectively screen for are prostate, breast, colon, cervix. Okay. It's the same list.
Right, got you.
So theoretically, there's a lot that we could do to actually combat cancer and lower the burden that we experience.
Wow, well, this is very, very interesting. I wanted to find out what are the causes and the risk factors related to cancer, its spread, and of course the characteristics.
Okay, when you talk risk factors, well, at least the way you think of it from a healthcare point of view, you think about modifiable risk factors and non-modifiable. So some things I can change, some things I cannot change.
Okay.
Right? So I'll give you the ones you can't change. Family history, right? So family history of cancers like prostate cancer, breast cancer, bowel cancer, even cervical cancer, all of those increase your risk of developing those specific cancers, right? You can't change your family history.
Correct.
What you can do is be more aware of your family history.
Okay.
A lot of people, if you ask them, well, what mommy and daddy had before they passed, they couldn't answer.
Know.
They really don't know. And we as adults tend not to discuss illness with our kids. So they grow up, all they know is that daddy died. They don't know what exactly he passed through. Yeah. So, but family history, we can't change that. Age. A lot of cancers increase in frequency the older you get. So that would be true for prostate cancer. That would be true for breast cancer. That would be true for bowel cancer, right? Again, three of the most commons. You can't stop aging, right? Time passes, you get older.
That's it.
Right? You just have to be aware of it. So those are your non-modifiables. The ones that we can change and avoid tend to be environmental exposures, right? And I'll just go through the list. Tobacco smoke, right? Whether first-hand or second-hand increases your risk of a collection of cancers.
Wow.
Everything from lung to mouth to esophagus to kidney to bladder would be increased. Even some types of leukemia, your risk is increased by smoking cigarettes or being exposed to secondhand smoke. Alcohol consumption, right? There's a very strong association between regular alcohol consumption and breast cancer in women. I don't know if you all would have been aware of the NCD survey that was completed by the ministry, the STEPS survey.
Okay.
Right? So it's a risk factor assessment of the population. Well, alcohol consumption among women has been increasing.
Yeah, I know that for sure.
So if that's been happening, then we could expect breast cancer rates among women
to increase.
Yeah, it doesn't happen now for now, but give it 10 years and
wow,
most things will show up. Yeah. Third on the list, obesity. Yeah. That would be increasing your risk for breast cancer, bowel cancer, in men, prostate cancer as well. Yeah. After that, diets, right? So diets that are high in animal fats and low in fruits and vegetables, right?
Okay.
And I think many of us are guilty, myself included, in terms of just not eating a good diet.
Busy schedules?
Busy schedules, and we just don't prioritize it.
Okay.
We don't think about it. We just eat whatever we could grab and we move on.
Whatever's convenient.
Whatever's available and convenient. Yeah. And then physical inactivity or lack of physical activity. Yeah. So once upon a time, getting to work meant walk down the street, maybe jump on a bus, jump off somewhere in town and walk to the office.
Right.
Nowadays, getting to work, yeah, and the car is like right next to the house.
Of course.
So if I have to walk 10 steps in any direction, it's a lot.
Yes.
Yeah, and then we have to compensate for that inactivity or lack of activity from regular activities by doing specific exercise. We have to join the gym.
Right.
We have to go and run canopy in the afternoon. Mm-hmm. But how many times do we get to actually do that in daily life? Unless we make it
unless we are intentional about
correct.
it.
You have to be intentional about it. Right.
All right. Well, at this time, we're going to take our first break and we'll be right back. Stay with us.
If you're wondering where to find top-tier quality tiles and products to refurbish or renovate your wall, floor, or pool, well, your worry is over. Come to D-Cell's Tile and Ceiling Center, Store Bay Local Road, opposite the Bonnecourt Primary School, Tobago, where you will find porcelain, mosaic, and ceramic tiles of the highest quality guaranteed. D-Cells Tile and Ceiling Center also stocks thinset, grout, tile cutters, and yes, windows. Plus, a friendly smile and service that's second to none awaits you. So forget the hassle and get all the quality tiles you need right here in Tobago at D-Cells Tile and Ceiling Center. Call us today at 460-8802, 639-8281. Opens Monday to Saturday from 9 a.m.
Powerlink Graphic Enterprise, Storby Local Road, Crown Point, Tobago, for a variety of quality printing products, including banners, posters, jerseys, flyers, and more. Graduation packages, get customized grad bags, mugs, newspapers, and the list goes on. Powerlink Graphic Enterprise, open Monday to Saturday from 9 a.m. Call 269-6996. We create ideas that inspire. Hi, I am Deanne, host of Transforming Lives One at a Time, and I would like to introduce you to our brand new segment, Good Vibes, Good News. And this is where you have the opportunity to highlight your good news. You can send your 90 seconds video to our WhatsApp number 868-701-2099. That's 868-701-2099. Let's hear some of the good news that we never hear about. Good vibes, good news. Inspiring hope. Celebrating wins. Truly grateful. Welcome back to the program Transforming Lives One at a Time. We are talking cancer with the doctor, Dr. Anthony Thompson. Well, Doc, we were talking before about, just everything surrounding this disease. I wanted to find out, what are the early warning signs that a person could look for? Is it something we can identify?
Okay, so first point on that, right? In terms of, we've discussed what the common cancers that you're likely to encounter, right? So when I talk about those top 4, that's going to be about 65 to 70% of the new patients that I see every year.
Okay.
Right? So that's where you really want to focus your energy on, right? So that's the first thing. Those tests, there are well-established screening programs for those, right? So we should be finding those patients before any symptoms appear.
Okay.
Right? You don't want to find your cancer with symptoms, because what that means in essence is that the cancer has reached a size where it could either press on something, it could bleed, it could do something to manifest itself.
Okay.
Yeah. Just to explain the game, the more advanced the cancer, the more advanced the stage at the point of diagnosis, the lower the odds of beating it.
Okay.
Yeah. So really, early detection is the game.
Best.
That's where you win the game or lose, right? So your first step, really, I would tell anyone, for your gender and age, you participate in the prescribed screening program, right? So if we say, well, look, we're in Tobago, we're going to test men for prostate cancer from age 45, you do your first PSA. At age 45, go do your first PSA.
Okay, yeah.
Right? If we're going to be testing for bowel cancer, we're going to be checking your first stool test at age 50, right? When 50 comes, you make sure and get it. If we want women with mammograms, we want to start your first mammogram at age 50, provided you have no family history of breast cancer.
Okay.
Right? Then we're going to age 40. Then we're going to get that done, the first one, and so on and so forth. And your pap smear every 3 years.
Yes.
So you do your regular screening as prescribed. In terms of just symptoms, if we take it cancer by cancer, so your first symptom for breast cancer is invariably going to be a lump or a change in the appearance of your breast, right? The change in appearance comes from the tumor itself pulling on different structures in the breast tissue causing dimpling of the skin, or one might feel heavier than the other.
Right.
Right? But of course, they're your breasts. You can examine them. You're free to do so. Examine your breasts. Right? It's yours. You don't have to.
It sounds so funny, right?
It's yours.
It's yours.
Yeah. So you do your regular self-breast examination, and you what we call breast awareness. Right? These are what my breasts look like. This is what they feel like. You keep checking periodically. If every month you did that,
Any change,
go
one
to the
time.
doctor. Yeah, go get it checked. Other common symptoms. So prostate cancer, again, you ought not to be diagnosed with symptoms, right? You want to have a high PSA test, and that's what leads to your diagnosis, right? However, common symptoms that men would present with for prostate cancer, a lot of times a man with prostate cancer also has a benign condition of his prostate called BPH. So what gets his attention is the BPH, because it causes difficulty in urinating. And you're up in the night urinating. And right. So that's what gets you to go to the doctor. Right. So it's not the cancer per se, but something coexisting with the cancer that brings you in. For cervix, abnormal bleeding. So, for instance, after intercourse, you have bleeding, right? That's not a normal feature. Abnormal discharge, right? But again, those are later signs. Yeah. For other cancers of the womb, a lot of times women, after they go through menopause and they're no longer seeing their monthlies, right, will develop bleeding, right? It's not that you're getting young again. It's not that the period has come back.
Right.
It could be the first sign of a cancer. Right? And then in general, very broad terms, you're looking at things like difficulty passing stool, right? Or a change in your bowel habits for bowel cancer. And you're looking at a cough that won't go away.
A cough?
Cough, yeah, for lung cancer as your first symptom. So you had the cold and you have a cough, and that's fine, and it goes away. Right. But this cough that you've had for the last 6 months, go check it out before you develop the shortness of breath that comes after. And then general poor appetite, fatigue, you're just tired all the time for no reason, and unexplained weight loss. Unexplained weight loss, especially in older patients, is a really useful one, but easy to miss. Yeah, easy to miss because, people get smaller as they age.
You might just say, I'd probably just lose my appetite.
Yeah, daddy just ain't eating. But at the base of it is something going on.
Dr. Thompson, can you explain the difference between benign and malignant tumors?
Sure. So the word tumor refers to any abnormal growth of cells, right? Tumors come in either benign, meaning that they're not cancerous, or malignant, meaning that they're cancerous. And there's actually not a clear black and white distinction. There's actually a spectrum of behaviors. Yeah. Now, the behaviors, like we would have mentioned earlier, that make it cancer are local invasion, unrestrained growth, and spread to distant sites. So, to contrast between benign and malignant, fibroids are a common benign tumor. Right? You'll have a fibroid that could get as big as my head, right? They'll just grow and grow and grow, unrestrained growth. But that fibroid will stay right where you put it. It's not going to spread. You're not going to wake up with a fibroid in your bowel.
Understood.
Yeah. It's going to stay in the womb, right? It's benign. Right. Compare that to a breast cancer, for instance, which could actually be fairly small at diagnosis and have already spread to the lymph nodes under the arm and already spread to other organs. Yeah. So that's the difference between benign and malignant. Benign, not cancerous; malignant, cancerous.
Right. Well, I want us to talk about our intake of, I think we touched on it just a little bit, our intake of food. Are there any specific dietary restrictions that we should observe as a preventative measure, and what lifestyle changes are crucial?
More fruits and vegetables. Yeah. Basically, modern diets come out of a plastic bag.
Yeah.
Everything is out of some sort of package.
Correct.
So the more your diet includes highly processed foods, right, the less healthy you are. Yeah. Whereas the more that you're eating vegetables and fruits, right, and you can eat meat, but not a lot of red meats because they have a higher fat content.
Okay.
Yeah. So it's really animal fats that you're trying to minimize or avoid. Yeah. I'll answer the question one time. Yes, you could have some pork. It doesn't mean...
the Adventists wouldn't like that.
I know. They're never the problem.
Right.
They eat lots of fruits and vegetables. But the, you know, you always get the question. So
Yes,
I could have some pork at Christmas.
Of course. Ham.
Ham at Christmas. Everything in moderation. But if
Right.
you're eating red meats 3 meals a week,
Okay.
right, you're overdoing it.
Understood.
Yeah. So a lot of people could tell you they eat pork more often in a week than they eat vegetables.
Okay.
Yeah. And just to clarify, provision counts as your starches.
Yeah.
It doesn't count as your vegetables. When we say vegetables, we mean greens, we mean salad, we mean bush.
Yes, yes,
Yeah.
yes.
The more of that you eat and the more fruits you eat, the better for you. Yeah. And in terms of other lifestyle changes, just get more active. Yeah. And that's not going to be good just for cancer. It's going to be good for diabetes. It's going to be good for hypertension. Basically, everything that's in the hospital now would be better if we lived different.
And not just say it.
Yeah.
But put the action into what we are saying. Well, Dr. Thompson, I want us to touch on the various treatments. I know there is chemotherapy, radiation, surgery, and of course you can fill us in on any other treatment options and what exactly they entail.
Okay. All right, so to put it in context, remember we had said earlier that your chances of surviving a cancer, right, are generally best predicted by the stage of the cancer when you were diagnosed, right? You have a much higher chance of being alive in 10 years if you were treated for a stage 1 tumor as opposed to a stage 3 tumor.
Understood.
Right? For most cancers, if it's a stage 4 tumor, we are not even able to cure you. Yeah. For most disease sites. Yeah. So the most natural treatment to start with would be surgical.
Okay.
Yeah. And surgery works really well if you find it at a stage where it's early, where there's not as much invasion into the surrounding tissue and not spread beyond the primary site.
Precisely.
Yeah. So if we found everybody at stage 1, nobody would die from cancer.
Wow.
Yeah. So surgery would be aimed at removing the primary tumor, and then generally speaking, they would sample the you know when you're small and you get a cold, you end up with what we call glands?
Yes,
right?
yes, yes.
So we call them lymph nodes. And every region of your body has lymph nodes that drain it. Yeah. So when you operate for a cancer, you try to get a primary tumor. You need to get a ring of clear, normal tissue around it. Because remember, you'll have invasion of the tissue, so you want it to look pretty normal.
Of course.
Right? And then you want to check the draining regional lymph nodes. Right? Once those are clear, then you have a question as to, do we need to do anything in addition to the surgery? Yeah. So a person might come out from operating theater and everything that the doctor could see, he took out.
Okay.
Yeah. And if we do nothing after that, in 2 years the person is dead because the cancer came back in their liver or their lungs or something like that. What's happening there is that cancer spread by tiny pieces of the tumor, of the primary tumor getting out and traveling through your bloodstream or your lymphatic channels to other organs, right? So when you come and operate and you take out what you could see, there's what you can't see.
That is the problem.
Floating about, and that's what actually kills you.
Of course.
Yeah, because that will then give rise to new tumor deposits around the body.
But my question is, as you spoke about the surgery, right after the surgery and in preceding weeks and months, are there constant checks? Is there any way of...
Right. So, okay, so you would have, I'm pretty sure the public is aware of what we call PET CT scans, right? So positron emission tomography, computed tomography scan, right? PET-CT, right? So that's probably our most sensitive test to find deposits, right? Because it shows not just actual tumor structures that you can see, but it will also show areas where there's increased metabolic uptake, right? Which would tend to signal that, hey, there's a little tiny tumor deposit there that we couldn't pick up with just a plain CT scan. The reality is even PET-CTs cannot find a cell or a small cluster of cells. Wow. Yeah. So you're always going to be looking at, we have an assessment today that says everything is out. We can't find any evidence of active disease in this patient, right? But at some point there is a chance that something comes back. The longest time to recurrence that I've seen in practice is about 20 years after surgery. Yeah, 20 years. And bear in mind that when we talk about clinical trial results, we talk 5-year survival and 10-year survival. 20 years.
Wow.
And this thing popped up again.
Oh my gosh.
Yeah, so coming back to the treatment question. So after the surgery, there's a question of, okay, what do we need as an adjunct to the surgery or in addition to the surgery?
Yes.
And that's where your systemic treatment comes in, right? So what we call, I prefer the term systemic treatment. Chemotherapy is a part of systemic treatment,
Okay.
right? The idea being that you're giving medication that goes throughout your body, therefore it can interact with small clusters of cells.
Okay.
Yeah. So if let's say I was diagnosed with a breast cancer and I had a tiny cluster of cells hanging out in my lungs, right? You're not going to be able to see it, but if you gave me chemotherapy and it went through my body, it could be able to kill those cells and create a hostile environment for any tumor clusters, so that they can't grow. And then, of course, we have radiation therapy. So radiation therapy is very focused. It's like that light shining behind us, right? It will target a very specific location in your body. So if, for instance, let's say after you do a breast surgery, let's say you just took out the lump and you may have tumor invasion into the surrounding tissue that you couldn't see with your eyes. Yeah. Radiation therapy to the breast would be a good way to tackle those potential residual cancer cells. Okay. Right? So it's a form of energy that you direct at a specific part of the body, and the energy from the radiation is what disrupts the DNA in the cancer cells. Right? Now, I'm hearing the question already. Right? Will it damage good cells?
Right.
Yes.
It will.
It will. Right?
And that's what radiation?
Radiation and chemotherapy.
And chemo.
Right? So I'll do the radiation first and I'll jump back to the chemo. Will it damage good cells? Yes. Right? It will disrupt the DNA of any cell that is exposed to the radiation. The difference is that normal cells have DNA repair mechanisms and can fix the DNA and recover, whereas the cancer cells lack those mechanisms. That's why they became cancer cells in the first place.
Gotcha.
Right? So when they try to replicate and they have to unwind the DNA to multiply, they can't do it and they die. Yeah. Okay. So the trick with radiation therapy is ensuring that you're staying within a safe limit for the normal tissue. And the way they do that is that they treat from different angles, basically. So a treatment plan for radiation is the same beam of energy we're using, but we turn you in different angles so that no one pathway to the target gets too much radiation. Yeah. Right. When you jump back to chemotherapy, in terms of harming good cells and bad, chemotherapy works by interrupting cells that divide rapidly, which is what cancer cells do. Right. But there are tissues in your body that have to divide rapidly as well. The tissues that make your blood cells, they have to keep replacing blood cells as they get worn out, so they have to be multiplying fairly rapidly. Yes. The tissues that grow your hair, the tissues that line your gastrointestinal tract, constantly being replaced. Those cells have to keep multiplying. So you find that when you give chemotherapy, all those cell types are susceptible to the effects of chemotherapy. The difference is that you have enough normal cells, right? You have 40 trillion normal cells to replace any ones that get damaged with your chemo.
Right.
Yeah.
And even in terms of hair loss, because I know that is a big thing with persons, it's like, oh, I now have to wear a wig and that kind of...
It's a lot of times, and as we talk in treatment, a lot of times I think a lot of the fear surrounding cancer is directed at the treatment and not at the disease itself.
Okay.
Yeah. So would your hair fall? Yeah. Your hair will grow back after.
Okay.
But hopefully the cancer is gone.
Right.
Yeah. I always have to try to encourage people to keep in mind what you're treating. I wouldn't give you chemo for the cold.
Right.
Yeah, something that you recover spontaneously from.
Yes.
It is potentially toxic, but it is to serve a greater purpose.
It is necessary.
A necessary evil, as they say.
Yeah.
So we don't dress up the fact that you get side effects.
Right.
And we manage the side effects as best as we can. And if you really can't make with the side effects, we can't give you, right? But at the same time, if it's necessary, it's necessary.
Well, we're going to take another short break and we will be right back. You're viewing Transforming Lives one at a time. Stay with us.
If you're wondering where to find top-tier quality tiles and products to refurbish or renovate your wall, floor or pool, well, your worry is over. Come to D-Cells Tile and Ceiling Center, Store Bay Local Road, opposite the Bonnecourt Primary School, Tobago, where you will find porcelain, mosaic and ceramic tiles of the highest quality guaranteed. D-Cells Tile and Ceiling Center also stocks thinset, grout, tile cutters and yes, windows. Plus a friendly smile and service that's second to none awaits you. So forget the hassle and get all the quality tiles you need right here in Tobago at D-Cells Tile and Ceiling Center. Call us today at 460-8802, 639-8281. Opens Monday to Saturday from 9 a.m.
Powerlink Graphic Enterprise, Storby Local Road, Crown Point, Tobago, for a variety of quality printing products, including banners, posters, jerseys, flyers, and more. Graduation packages, get customized grad bags, mugs, newspapers, and the list goes on. Powerlink Graphic Enterprise, open Monday to Saturday from 9 a.m. Call 269-6996. We create ideas that inspire.
Welcome back to the program. Dr. Thompson, I must ask this question. Because a lot of times, from the time a person hears that word cancer, it's like they step into panic mode. Let me put my affairs in order. Oh Lord, I'm going to die. And that is just the reality of some person's mindset. And on this program, we like to be real. Because I said too long we have been sweeping things under the carpet. So I'm just going to come out and ask you that, being practical, is being diagnosed with cancer an immediate death sentence?
Immediate death sentence, most times no, right? Now, in the era of non-communicable diseases or chronic diseases, our expectations, you have to be it's different.
Yes.
Right? So for instance, many times I'm not curing disease and I'm not saving lives in that how you traditionally think about it. Right? So if I have hypertension and I'm taking my tablets for my blood pressure, I'm not getting over my blood pressure. If I stop taking those tablets, the pressure will go back up.
Right.
And I'll have the stroke or whatever I'm trying to prevent. The reality is that what I'm trying to do is not to live forever, but to live longer.
Right, so you're managing it.
So I'm managing it, right? So am I dying? Yes, I am. Am I going to die next week? I hope not, right? And that's a difference in perspective.
Okay.
So long ago when we talked about infectious diseases, you got your antibiotics or whatever, and you got over it.
Yes.
And you were well, and you went about your business. You were cured. Chronic diseases is a somewhat different game. When we specific to cancer, what you're looking at is, at least from my perspective, what you're looking at is, can I get to a long, functional life
with
this patient? So if you came to me and said, we have this magic thing and everybody is going to live to 85 and be in a good condition and play football up to day 84 and die at 85, I'd say, yeah, give me some of that.
Okay, of course.
That's great. In cancer, the chances of you living a long and fully functional life are really dependent on the stage at which we intervene.
Okay.
Yeah. If we intervene at the right stage, right, at an early stage, then that long life with full or near full functionality is on the cards.
Yes.
Yes. And for some cancers, it's almost guaranteed. Yeah. The challenge is that because of the fear factor.
Yes, that panic mode,
Correct.
that
So
fear.
people panic. Just the suggestion that this might be a cancer is enough to scare people. And what they do what people do when they're scared, and it's an understandable natural reaction. You get scared, you avoid. So I don't go for the test.
Right.
I don't go for treatment.
I don't want to know.
I don't want to know. And then what could have been solved is now something that we can't solve.
Okay.
Yeah. And that fear has been maybe one of the biggest obstacles to us making progress on cancer. Because we have hospitals, we have very good surgeons, we have chemotherapy available, we have access to state-of-the-art radiation therapy.
Yes.
And yet, if we keep feeding that system with people with advanced stage disease, we just never get the benefits that we ought to. Yeah, so that's why 100 times I will come and do a talk like this.
Yes.
Have a chat like this, because that fear, if we could sort of make this more normal, if we could normalize cancer.
Oh, wow.
Yeah, just saying the word.
Just saying the word alone, because up to this morning I was having a conversation and I was telling the person I'm heading into the studio, and the topic today, she said, oh my gosh, my dad just passed away Christmas from cancer.
Yeah.
And, I was talking to another person, and the person said, my sister and my co-worker. And I said, but this cancer is a demon.
Yeah, yeah. And in a community setting like in Tobago, we all know each other, basically.
Exactly.
Yeah.
And we all know someone who has been affected by it.
Correct.
Co-worker, an
Correct.
aunt, an uncle, a grandfather, someone. And this is very, very heavy in my heart.
So I'll give you a true story from my personal life. My grandfather, right, he was a sportsman, national sportsman actually. But he was scared of cancer, right? So he developed a tumor, right? And I remember as a child, my mom describing to me that nobody in the room said the word cancer.
Yeah.
So Grams would be feeling this thing and not saying anything to anybody. And everybody who had been with him to the doctor knew what he had, but nobody ever spoke about it. And it's because of the fear. This intense fear that, death is
just saying the word.
Suffering and
because
death,
long
basically.
time they used to say the big C.
Mm-hmm. Yeah. I was at a function, it was a walk, right? And then it was a cancer walk, or cancer awareness walk.
Yes.
And Nurse Frank, who's the head nurse at Oncology, she was giving a talk. And she just started her talk by, can we all say the word cancer?
Yes.
Let's say it. But if we could get past the fear of it, right, we would make better decisions, which would lead to better results. And then hopefully that would snowball into us not having to be so scared.
Of course.
Yeah. So people would tell you, I don't do the pap smear because I don't want to know.
Yeah. But that is bad.
You
should know.
Yeah.
Please know.
Yeah, I mean, please find out early so
exactly.
that. And the funny thing is, if you find cervical cancer really early, you don't even have to take out your womb.
Right.
You can literally do a cone and get the tissue out.
Yes.
Yeah, but we are scared, so we don't engage. And when when we do find out, when we have no choice but to engage.
Right,
It's
of
because
course.
it's later on.
It's late. Because I was speaking to a gentleman, and I was asking him about like prostate exams and stuff. He said, listen, I am not going to trouble anything that didn't trouble me. So if I, and it may sound funny, but he's saying, if it's not affecting me, I'm not going. And I'm like, but you need to go and check before, if anything has to affect you, at least you would be in a better position, or the best position, to be able to take care of it before it becomes.
Yeah,
Is it that we need a bigger educational drive? Because we can't be naive. Cancer is on the lips of many persons around the world. And the fear of it, it's like we don't want to talk about it. We don't want to think about it. We don't even want to do a test because. So maybe this is a perfect opportunity for the TRHA to probably go on an educational drive, letting persons know, yes, we know you hate cancer, but let's do the test to ensure that even if we find it, we could find it early.
There's a lot of, how to put this? So fear is a natural human response.
Correct.
And it colors everything we do. It changes how we make a decision. And a lot of times it leads us to the most unhelpful decision.
Yes.
Right? We go the exact opposite direction
True.
to what we should do. But fear is a very human emotion.
Yes.
I don't think we could educate it out to people. Yeah. But I think what we can do is make it a lot easier, and we can encourage people. Yeah, so for instance, a relative of mine living in the US had breast cancer, right? She found her breast cancer because to get on a health insurance, she had to do a mammogram.
Wow.
Otherwise the risk of insuring her, they just wouldn't entertain it. And that's how she found out. Making certain services more accessible, and making them friendlier. Yeah. So it's bad enough that you have to confront this ugly thing.
Yes.
And you're really not sure what's going to happen or not, but we can do better in terms of making it more humane, what we're doing, how we're doing it, how we're delivering information.
Correct.
Yeah, so there's a lot of room for us as a country, I think, to make improvements in terms of just making screening more doable for people.
Yeah. Encourage persons to come on board.
And if I had to bet money on a region in the country to win or to get it done right first, I would bet on Tobago.
Okay.
For the simple reason that Tobago still functions as communities.
Right.
Yeah. If you get the right people to say, hey, I am doing this, everybody else kind of looks and says, yeah, well, if someone
let's come on board.
Let's go and do this, you know.
Yes.
The screening bus coming down this weekend.
Of course, let's go.
I'm
planning a trip.
We're doing it. And we still, in Tobago, there's still a very strong sense of community.
Yes.
And every opportunity to engage in that way, I think will lead us to a better prospects.
Of course. Well, Doc, as we begin to wrap up, I want us to talk a little bit about how crucial that family support is for a patient that is going through this kind of ordeal. How is it that we have to help educate our family members more? Tell us about that.
The hardest part in interacting with family members, and a lot of parts of it are hard, but you don't know how to do it until you have to do it. Yeah. So there's a lot of need for family to support, but also for family to get support.
Yes.
Yeah, because when you're confronted with this horrible news, right, you yourself are scared.
Yeah,
you yourself are scared. So I've seen people. I remember once a relative was telling me, I know so-and-so has this thing, but I just can't go and see them.
Yeah. It's like you don't know what to say.
I don't know what to say, and when I look at the person, I see this is me. I could picture myself in the same situation, and I can't face that.
Yes.
You know, so there's a lot of emotional work, psychological work to get us to be able to stand in that space. And then there's a lot of frustration on the part of the patient, on the part of the family. You know, one thing I always try and, I just bring it up because I know it comes up in a consultation. I say, hey, you have an idea as to how much mommy or daddy should eat, right? They're not eating, not because they're bad or they're upset with it. They're not eating because they literally can't eat.
Yes.
The tumor is producing things in their bodies that's telling them not to eat, right? So if they ask you for something and when you bring it, they only take 2 bites and put it down.
Don't be
vexed, don't be frustrated. Upset. Correct. But when people can be talked through some of these experiences, then there's a little bit more peace and a little bit more calm.
Yes.
But the family support is crucial, even workplace support.
Of course.
Yeah. People can be at risk of their livelihoods.
Yeah.
Yeah.
And that alone can bring on depression.
Correct.
So we're looking at counseling services, we're looking at, so not just the family support, but counseling for family, counseling for the patients. It's a holistic.
Yeah. And our expectations of what a cancer patient should look like.
Yeah.
You know, I have a patient who's doing so well that the people that work with her don't think she have
exactly
making it up. You know?
Yeah.
So there's a lot of need for better support in terms of just more empathetic support.
Yes.
But I would say as well that one of the joys in the job is actually seeing families show up.
For others.
For their loved ones, and seeing the tender care that is exchanged between families or husband and wife, well-wishers, friends. You know, people often are not left alone. They're not abandoned.
And that is so wonderful.
It matters a lot.
That is so wonderful. Well, I want to touch quickly on what are the latest advancements in cancer treatment and how do clinical trials work?
All right. So if you, just a very broad context. So when you think about cancer treatment, you think in surgery, radiation, and systemic treatment. Right. So on the systemic treatment front, what has happened is that as we have gained a better understanding of the genetic processes and the metabolic processes involved in a tumor's growth, we now design molecules to block that.
Okay.
Yeah. So there's actually some really good medications that will interrupt a specific genetic defect and block it. Yeah. The next step in this evolution would be actually using some of the same technology they did for the COVID vaccine.
Okay.
Those mRNA-based things to correct faulty genes.
Okay.
As a therapeutic strategy, right? When we look at radiation, the gist of it is that if I could take the tumor out and put it under the machine and just crank up the dose, I'd kill every last cancer cell available. I can't do that because of the constraint of the normal surrounding tissue. Right. So then what happens, the advances in radiation therapy are about being able to treat the tumor, while still maintaining safe limits on the tissue, right? And that comes to how we break up the radiation dose. It comes to better imaging.
Direct.
Things like, direct imaging. So when I was working at St. James initially, the imaging for radiation planning was x-rays, plain x-rays. So if, for instance, you wanted to radiate a cervix, you put like a metallic marker on the person's front, and they would lie down on a metallic plate at the back, and then you do your x-ray from the side. So you could judge where the back of the person is and where the front of the person is, and you know, well, I'm aiming for just about there.
Yes.
Nowadays, planning is done with a CT scanner.
Okay.
And a CT simulator simulates what the beams of radiation will do in a given plan. So the accuracy goes right up. Yeah. And with the accuracy going right up, of course, you can treat a higher dose, meaning a better cure rate.
Right.
And for surgery, Trends in surgery tend to be with different or newer techniques, robotic surgery.
Yes,
You
I
know,
heard
where
about that.
somebody is remotely
Yes.
doing a procedure. And
That's amazing.
it's crazy. But bringing it back to the other part of the question about clinical trials. So what a clinical trial does essentially is take one group of people, or they'll take a sample of people who have a condition, right? And one group gets what we call the standard of care, right? And another group among that sample gets the treatment that we're testing,
Okay.
right? And then you compare the average results between the two groups to see if the test group did better than the standard of care. So of course, that leads to what we call a statistically significant difference.
Okay.
So for instance, it may mean that, let's say we're talking about stage 4 patients with bowel cancer getting drug A versus drug B, right? Patients in the group on drug B might actually live on average 2 months longer.
Okay.
Right? The caveat to it is that just because it was statistically significant does not mean it was clinically relevant. Yeah, because you also have to factor in, when you get these trial results, what's going to be the cost of implementing this new strategy.
Right.
So we tend to believe newer is better.
Yeah.
But it's not always better, and a lot of times it's better by such a small difference that is like, okay, keep what you have until something significantly better comes along.
Yes. Well, Doc, I want to give you the opportunity to quickly give a word of advice to someone who just received a diagnosis of cancer. What would you say to them? They are now, everything is just up in the air. They are now at a time that they don't even understand what is taking place. What would you tell that person as we begin to wrap up?
Take courage. Yeah, take courage. If you move, right? If you move towards the threat, run into the storm, you have a much better chance of surviving it than if you run away from it. Yeah. So it's really a test of telling yourself, no matter all the fear is telling you go the opposite direction, you have to head towards the situation. It's one of those things where avoidance will kill you. Yeah. And if it comes to the point where when you do get the information that you need, your illness is not curable, right? It does not mean that you give up and toss your hands in the air. Yeah. Because even if I cannot cure, we could still extend life, and we can still make life better. Yeah. Better meaning that you live longer, you're more functional, and you have fewer symptoms, right? Or your symptoms are more easily managed. So take courage and head into the storm.
Yes, well, thank you so much. Well, Dr. Thompson, I want to thank you so much for being a guest on the program and for giving us such vital information and for so competently handling this topic today. So thank you so much for coming in. We have been speaking with Dr. Anthony Thompson from the Oncology Unit at the Tobago Regional Health Authority, and we want to really thank him for taking time off his busy schedule to be here with us today. As stated earlier, being diagnosed with cancer is not a death sentence. I repeat, it is not a death sentence. Once there is life, there is hope. As you begin to explore the options available to you in the fight against this disease. All right, ensure you do your checks, your pap smears, your prostate exams, and whatever you have to do Do your part. All right, well, viewers, this is where we leave things for today. You have been viewing Transforming Lives One at a Time. As usual, you could check us out on all our social media platforms. We're on TikTok, Instagram, YouTube, and of course, Facebook. As usual, I leave you with the definition of transformation, which is an internal shift that brings us into alignment with our fullest potential. Hey, we've got this. See you next time.